Good evening, all. Welcome to doubt solving session of oral medicine and radiology. Let us wait for 30 seconds so that everyone can join in and we'll start with the discussion. So I hope you all have attempted test and have gone through discussion video. And still, if you have got any doubts, we have circulated Google Form so that your doubts can be solved. Okay, so I have gathered some of your doubts. So let us start with the first doubt. Okay, uh, somebody has asked key differentiating features of fibroosseous lesions. All right, so what are the main fibroosseous lesions that are asked in exams? That will just write it down, and then how will you differentiate with the other entity that we are going to discuss? Okay. Okay, so first entity that we have is fibrous dysplasia, most commonly asked, you can say the fibroosseous lesion. All right, and we are going to differentiate from ossifying fibroma. All right. The second one that we have is the FCOD, okay, which is florid segmento osseous dysplasia. We are going to differentiate with the Paget's disease. All right. Now, uh, what is the difference between fibrous dysplasia and ossifying fibroma? All right. So, fibrous dysplasia, okay, basically, uh, affects, okay, it mainly affects the maxilla. This we all know. All right. Then it is seen or affects maxilla mostly unilaterally. All right. Then it has got ill-defined borders, ill-defined borders, or we can also say it has got blending borders. Okay. That means if this is a normal bone, all right, this is a normal bone trabeculae. The fibrous dysplasia will be just looks as a granular bone pattern. Okay, and it will have a blending border. Okay, so granular bone pattern is seen in the fibrous dysplasia. All right. Okay. Now in fibrous dysplasia, what patterns do you see or what appearances do you see? Okay, so we will see four appearances in fibrous dysplasia. First is fingerprint appearance. Second one we have is the ground glass appearance, the most famous one. Third one we have is the cotton wool appearance. Sometimes it shows cotton wool appearance. And fourth one we have is the orange peel appearance. Orange peel appearance. All right. So these are some appearances that fibrous dysplasia shows. All right. And what is the epicenter? Now, when you differentiate between two entities, you need to know the epicenter of the disease. All right. So, epicenter is where the entity is located. Okay. So, with respect to inferior alveolar canal, inferior alveolar canal. That means your entity is located either above the canal or below the canal. All right. So this depends on the epicenter of the entity. Second one, the location, of course, whether it is located in maxilla or mandible, that you will have to remember. All right. So this fibrous dysplasia, I'm going to differentiate it from the ossifying fibroma. All right. So here, if you look at this, okay, fibrous dysplasia shows or in three stages basically. All right. And we are going to differentiate with the ossifying fibroma. All right, ossifying fibroma. So ossifying fibroma mainly occurs as a unilocular entity. All right. Most common location is the posterior mandible. Okay, posterior mandible. Then it will seen as a well-defined, okay, well-defined entity. It will have somewhat dome shape. Okay, the body of mandible will be seen as a dome-shaped enlargement, and with that we have round radiolucency with calcifications. The radiographs I have put to just to differentiate between these two entities. Okay, it will look as a round radiolucency with calcifications. Okay, so these are some points that is differentiating from the fibrous dysplasia. Okay, fibrous dysplasia occurs in maxilla, unilateral involvement, ossifying fibroma, posterior mandible, okay, unilateral involvement, but it will be well defined, whereas fibrous dysplasia will have a blending border. You will not be able to differentiate the normal bone with the abnormal bone, all right? And the ossifying fibroma will be seen as a shaped enlargement, whereas in fibrous dysplasia, it is mostly in rectangular, you can say rectangular uh, involvement, okay, or enlargement of the bone. All right. And in fibrous dysplasia, also the epicenter of fibrous dysplasia is mostly below inferior alveolar canal. Okay. So below inferior alveolar canal. Fibrous dysplasia occurs below inferior alveolar canal. This is the epicenter of it and most differentiating, important differentiating point. Okay. If you look at the radiograph of it, this is a fibrous dysplasia. Okay. This is a fibrous dysplasia. So here we have the maxilla. Okay. And this is a abnormal bone, granular bone pattern that you see is called as ground glass appearance. Okay. Ground glass appearance. All right. And you will not be able to differentiate this with the normal bone. Okay. It just like it blends in the normal bone. Okay. That is why. And how will ossifying fibroma looks? See, look at this. It will have well-defined dome-shaped enlargement in the posterior, affecting the posterior mandible. All right. And it will have a unilocular radiolucency, and this is the calcification that you see inside this. All right. So this is the differentiating points between fibrous dysplasia and ossifying fibroma. All right. Then we have the, or we have most important, you can say, uh, entity, which is Paget's disease, and we have FCOD, which is florid cemento osseous dysplasia. Now, what is the common points between these two? Okay, these two shows cotton wool appearance. Cotton wool appearance. Now, what is the differentiating point between these two? All right. So, in Paget's disease is a skeletal disorder. It affects all the or most of the skeletal bones, all right, involving or including jaw bones. All right, not that it only affects the jaw bones. Okay, florid cementoosseous dysplasia mostly affects the jaw bones. All right, and Paget's disease is basically abnormal resorption and deposition of poor quality of bone. All right, and that involves the multiple bone or affects the multiple bone. All right. And Paget's disease mostly, you can say the epicenter of it is below inferior alveolar canal. Okay. Below inferior alveolar canal if it affects the mandible. But what is the common site? Maxilla. Okay. Paget's disease mostly seen or affects maxilla, and that too bilaterally. Okay, that too bilaterally, and greater than 40 years of men are most commonly affected. All right. And what is the uh, important points in FCOD? FCOD is basically what is the epicenter of it? It is above inferior alveolar canal. All right, above inferior alveolar canal. And more than two quadrants are involved, okay, in FCOD. More than two quadrants are involved in FCOD. So what is the difference between these two? We have discussed here. All right. Paget's disease also shows more features which involves hypercementosis. Okay, hypercementosis is seen in Paget's disease, not in the case of FCOV. Okay, florid cementosus dysplasia. Now, if I show you the say a radiograph of it, this is basically FCOD. Okay, now FCOD, you will appreciate the radio opacities. Okay, affecting two quadrants, at least two quadrants. And this FCOD occurs in three stages. Starts with the radiolucent, then comes to mixed, and then comes to completely radiopaque. All right, completely radiopaque. Uh, and this FCOD, okay, involves two quadrants. Okay, it can involve more than two quadrants. Mostly affects the mandible. All right, mostly affects mandible. Okay. This is the difference between the FCOD and the Paget's disease. Most commonly asked, you can say one more entity is there, which is cherubism. Okay, cherubism mostly occurs as a multilocular radiolucency. Okay, multilocular radiolucency, and it affects the jaws bilaterally. Okay, mostly affects the mandible. All right, mostly affects the mandible. So these are the features which is seen in cherubism. Also in clinical features, you will be able to see eye raised to heaven appearance. Eye raised to heaven appearance. Okay, so these are some radiographic features, and this is the clinical features that you will see in the cherubism. These are most commonly asked entities. Just remember the main points of it. You will be able to differentiate between them. All right. Coming on to the next doubt. Okay. This was one of the questions asked in the test and discussion test of oral medicine and radiology. All right. So, a young man with a carious molar reports with long standing mild pain and swelling. Okay. With respect to tooth on buccal side. Okay. Radiograph shows new bone formation uh, below the periosteum, and this condition is called as a proliferative periostitis, B Gary's osteomyelitis, C chronic osteomyelitis, and D both A and B. All right. So they have mentioned the key points, that is a young man with carious molar, so that there is a long-standing infection or and swelling. Okay, and patient is having mild pain, and they have mentioned radiographic features of new bone formation. Okay, below the periosteum. Okay, now this is basically a acute phase osteomyelitis. All right, this is a acute phase osteomyelitis. Now there are synonyms of it. Okay, synonyms are acute suppurative osteomyelitis. Then we have pyogenic osteomyelitis. Then we have subacute osteomyelitis. All right. Then we have something called as Gary's osteomyelitis. Gary's osteomyelitis. And we have proliferative periostitis. Periostitis. So these all are the synonyms of one entity. All right. And you just remember Gary's osteomyelitis, and these are the synonyms of Gary's osteomyelitis. And most common source of this Gary's osteomyelitis is periapical infection. Okay, long-standing infection from non-vital tooth. All right. And it is thought that inflammatory exudate, inflammatory exudate due to long-standing infection, it spreads subperiosteally, and it elevates the periosteum. Okay. It elevates the periosteum, stimulating new bone formation. Okay. That we have studied already. Okay. And it is most common in younger people. Why? Because the periosteum is loosely attached in the younger people. So therefore, what happens here is the repercussion of it, and most common site of it is mandible. So mandible is most commonly affected, and why? Because of poor supply of blood in the mandible. Okay, due to thick cortical plates. Okay, and this acute exacerbation, acute phase or acute exacerbation of this infection may produce the uh, this inflammatory exudates will lift the periosteum, which is loosely attached in the younger people, and it will stimulate the periosteum to form new bone. All right, and this process continues and continues and continues, and then we'll have what is called as onion skin appearance. Okay, so in Gary's osteomyelitis, we'll be able to see onion skin appearance due to this continuous process of new bone formation. And there is a massive amount of new bone which is formed, which is also called as proliferative periostitis. Okay, proliferative periostitis. So the answer for this question is option B, which is both A and B because they are synonyms of each other. Proliferative periostitis and Gary's osteomyelitis. All right. I hope this doubt is clear. And now I have put the radiograph for your better understanding. Okay, if you look at this, you have this, the inferior border of the mandible. And below that, there is one more outline, which is a new bone formation, which is due to this continuous new bone formation process. Okay. And this process continues and will get somewhat this appearance. And this appearance is called as onion skin appearance, which is a characteristic feature of Gary's osteomyelitis. All right. Okay. So this was the second doubt which were asked The third doubt we have is indications for different radiographic uh, views. Okay, indications for different radiographic views. This is the you can say most commonly asked question. Okay, and I have made up one table that you just remember. Okay, so that the questions asked directly based on what is the best view for condyle, what is the best view for zygomatic arch, what is the best view for fracture in the ramus or body of mandible. Those questions you will easily able to answer with this. Okay, so starting with the first. Okay, for fracture of zygomatic arch, okay, and the abnormality in base of the skull, okay, we take submento vertex view. All right, we take submento vertex view for fracture of zygomatic arch and the abnormality in the base of the skull. We take submento vertex view. All right, and the fracture of zygomatic, the specifically the fracture of zygomatic arch, the variation of submental vertex is your jug handle view. Okay, specifically for fracture of zygomatic arch. All right. Next one we have is the fracture of zygoma, maxillary sinuses, abnormality in maxillary sinuses. All right. Fracture in the nasal septum, okay, will be seen in the waters view. Okay, so waters view will be the best for your fracture of zygoma and maxillary sinus or nasal septum view. All right. The next we have is the condylar neck fracture. Condylar neck fracture will be easily seen in the reverse Towns view. All right, reverse Towns view. Okay, then we have condylar fracture. Okay, condylar fracture, and whether it is medially displaced or laterally displaced, that you will be able to say using transorbital view. Medially or laterally displaced condylar fracture. All right. Medially or laterally displaced condylar fracture is seen in transorbital view. All right. Now, for the medial aspect of condyle to see medial aspect of condyle, medial aspect of condyle, transpharyngeal view, transpharyngeal view. To check the lateral aspect of condyle, to check lateral aspect, we use transcranial view. So these are very important to the different aspect of condyle and which view to use. Okay, they are very specific, so you need to remember these. All right. Okay. Then we have the coronoid process. Coronoid process of mandible is seen in PA view. Okay, is seen in PA view. Okay. Then we have the fracture of body and ramus of mandible. The order lateral oblique view. Lateral oblique view. All right. To check the bony ankylosis, bony ankylosis, we will just order CBCT, okay, or CT scan. All right. Disc dearrangement can be checked using MRI. Okay, using MRI. So these are the most commonly asked, all right, commonly asked views. Okay, the direct questions can be asked based on these views, all right, and you need to remember the specific, you can say specific aspect, like a medial aspect of condyle will be seen only in transpharyngeal view. The lateral aspect will be only seen in transcranial view. All right. So that's how you need to remember, so that the direct question asked based on these topics, okay, you can answer very uh, easily. All right. Okay. So now I'm going to take your doubts. I'm going to take your doubts. Okay. Sonali Gupta is asking, what is the main difference between papillon-Lefevre and nevoid basal cell carcinoma syndrome? Okay, so this question, see, these syndrome-based questions are mostly asked from the oral pathology. So, okay, Dr. Srishti will be able to guide you through these questions. All right. Okay, difference between osteoid osteoma and ossifying fibroma. Ossifying fibroma I have discussed, okay, in this, you can say, uh, at the start of the lecture. Okay, what is osteoid osteoma? Basically, it is a benign tumor, okay, affecting the long bones, okay, the completely radio opaque structure, okay, and it is if you differentiate with the ossifying fibroma, okay, it occurs in the unilocular form. It will be seen as a radiolucency, and then inside which we'll see the calcifications. Okay, and in osteoma, you will be able to see the radio opaque, complete radio opaque, well defined entity affecting not only jaws but in the other long bones also. All right. Then we have if fibrous dysplasia is more common in maxilla. Yes, I mentioned if it affects mandible in some cases, rare cases, then it will be seen. Um, it will be seen with respect to inferior alveolar canal. Okay, then only you will have to see with respect to inferior alveolar canal, not in the case when it is affecting maxilla. Okay, when it is affecting mandible, then you can differentiate with respect to inferior alveolar canal. All right. Um, Yes, so somamide and juvenile ossifying fibroma, how will you differentiate these two? Mostly the histopathologic differentiation is very important in such cases. Okay, radiographically, you will just have to give the diagnosis as a ossifying fibroma and advise the biopsy. Okay, in histopathologic examination, you will be able to differentiate these two. All right. Uh, I hope I've cleared all your doubts. If you have any doubts, you can post it in the comments below. Otherwise, we'll end this session. Okay. So we'll end this session. All right. I hope I cleared all your doubts. It was lovely interacting with you all. And still, if you have got any doubts, you can post it in the comments below. I am more than happy to answer those. Or you can connect us on Telegram channel. All right. And post your doubts there also. Uh, okay, guys. Thank you all. Take care and good night.